Hello, I did my poster on acute pancreatitis. So first, I think it's important to just go over what the pancreas's function is. It creates the hormone insulin that helps us control our glucose levels, but it also produces and releases lots of different enzymes that help us digest our foods. They digest our fats and our starches and our carbs and our proteins. Um, and so what happens then in acute pancreatitis is the pancreas actually overproduces these enzymes, or it prematurely activates all of these enzymes, and it causes the enzymes then to actually digest the pancreas. It's called autodigestion. So it can be very sudden. It's very crippling pain, and it kind of radiates. So as you'll see there, I have epigastric area, upper mid abdominal pain. It just kind of radiated all across his stomach and through his back. He was nauseous and vomiting. He was sweating. He was tachycardic. He was tachypneic. His labs, they were all elevated. So with his elevated amylase and lipase levels, and then his CT results coming back and showing inflammation of the pancreas and of the C-loop of the duodenum, it was then diagnosed that he had acute pancreatitis. For 3 nursing diagnoses, I have one is acute pain related to the pancreatitis as evidenced by the patient's inability to sit up or eat. He was a fully ambulatory man, but his pain was so strong that we had to use a sliding bedboard to get him over onto a cart so we could get him to CT. He hadn't eaten in the last 18 hours. And then the patient rated his pain at 10 out of 10. Another one was his anxiety related to the hospitalization. My patient was an alcoholic. He was a smoker, and he also has a history of PTSD, or has PTSD. So being hospitalized was really increasing his anxiety. He was mostly worried about not being able to go outside and have a cigarette. And then my last one is risk for unstable blood glucose control related to autodigestion and the pain. As far as planning goes, it's always good on day 1 to set or to start the discharge teaching. And so the first thing that we wanted to do was set a goal for discharge. We had it set for 5 days after his admission. Our next thing was that we wanted to transfer the patient to a longer stay floor. We wanted the patient to verbalize that his pain was relieved and show that he was able to mobilize himself again. We wanted labs to come back at a normal level. We wanted to start aggressive fluid replacement as soon as possible, as it's shown in the management of acute pancreatitis by Santhi Vij, that it just starting with aggressive fluid replacement has shown a reduction in mortality and morbidity. Acute pancreatitis, because it's so sudden and it's so crippling, and because it's necrosis of the pancreas, it can actually spread and cause complete organ failure. And so just starting aggressive fluid therapy has just shown a reduction in the mortality and morbidity rates of acute pancreatitis. We planned for pain management. We planned for the patient to safely withdraw from ETOH and be able to control his nicotine addiction while using some nicotine patches. Implementation then was medicating the pain. We used morphine, Dilaudid, and hydrocodone. When he was admitted to the medical surgical floor, he was placed on a morphine drip that was patient controlled. And then we wanted to dim the room stimuli, so we shut the door, turned off the lights, we turned off the TV that was running in the background. We wanted to measure and document his intake and output. With the aggressive fluid therapy, it was important to make sure that he was peeing off all of that water as well. We wanted to place the patient on seizure precautions due to his withdrawal from alcohol. And then we wanted to administer Ativan and lorazepam to reduce his anxiety levels. And then lastly, we wanted to make sure that we maintained a therapeutic level of nicotine. As far as evaluation goes, by the end we wanted him to tell us that his pain was a 0 on a scale of 0 to 10. We wanted to make sure he had adequate hydration. We wanted his labs to return to a normal range. We didn't want him to be experiencing any symptoms of alcohol withdrawal or nicotine withdrawal. And we just overall wanted the patient to return back to his baseline. I have two sources: The Management of Acute Pancreatitis by Santhi Veej. He's a gastroenterologist in Rochester, Minnesota at Mayo Clinic. And then I also had one, Predicting the Evaluation of the Severity of Acute Pancreatitis, from the American Journal of Surgery. Thank you for listening, and let me know if you have any questions about any of the cares or any of the pathophys, as I'd be happy to answer. Thank you.